things were still very challenging. Abel still needed a couple more rounds of chemo and radiation. But now we had the full force of the palliative care team behind us, working with us on every decision. And you know, as hard as those next 2 rounds were, and I think they were worse than the first 4, we were empowered then. We had both the ability to make the choices and be a part of the decision team, but also to be making the decisions on symptoms. And
I'll say it made me angry initially, because, you know, it was like he was suggesting that we should give up. But that was very, very momentarily, maybe even instantaneous. I mean, we're talking just a few moments, and then the very next thing I felt was relief. Finally, somebody is saying out loud what I was feeling deep down all along, and I wasn't going to say. I wasn't going to suggest that to a doctor who, you know, wasn't thinking along those lines. It just didn't seem appropriate.
Until that 4th round of chemo, I remember just how incredibly difficult it was, and sort of coming to some of the same conclusions Rachel just mentioned about wondering what were our goals here. Well, you know, here we have a case where it's beginning to become questionable whether Abel would even survive the treatment. If he survives the treatment, whether it would even work. And if it worked, there's a high chance this cancer comes back. But even if it never comes back, the doctors are telling us that Abel's brain injury is one that he'll never recover from, have any meaningful recovery from. And so you begin to see this incredibly hopeless and despairing situation. And we requested, I remember that evening, we requested a meeting with Dr. Kane, and he came up well after business hours. And that's the meeting where we sat down and went through the different stages and different potential goals of what we could choose as options for Abel.
And Abel's brain injury was an important part of that discussion, because it would have been, I think, a very different discussion if he'd been a, you know, normally functioning 2-year-old.
Most of our first meetings were entirely focused on symptoms. Nausea, pain control, treatment for the mouth sores, and those sorts of things. A lot of our discussions centered on that initially, and sort of through the course of, I couldn't tell you how many, but several conversations led up to the conversation where we talked about overarching goals for Abel's treatment.
Does that sequence suggest that the time was important for you to think about these issues before coming to a decision?
It might have been, from my perception, that Dr. Kane was trying to get a good feel for us as well, to try and discern where we were at in terms of our experience with Abel.
I think that's right. I think for us, I think it was necessary for us to have the time, and I think he discerned that, but maybe not every case is like that.
For me, I found it surprising to, perhaps because I was a medical student, to sit down with physicians who I thought embodied what all physicians should have been about, and that was presenting choices to the patient and allowing the patient to guide the treatment. And that was just surprising to me, to step into the medical world with my son as the patient and have been stripped of all ability to make choice. You know, we're not talking about antibiotics for an ear infection here. We're talking about you know, life decisions, very big decisions, and to have taken that choice away from a patient was very surprising to me. I found that to be incredibly surprising and disheartening, because here I am aspiring to be a physician, and what I have is an ideal physician I found embodied in a palliative care doctor.
And the palliative care docs, they're the ones that rose above everybody else in terms of making things better. That's what they did. They made things better.